the School of Social Work and from the Interprofessional Education Program, and I am the social worker for the team. Next we have Tim Randolph, who is the medical technologist, and he's from the Clinical Lab Science Department. Next, Erica Pierce is our pharmacist, and she's from the St. Louis College of Pharmacy. Next to her is Kim Levenhagen from the Physical Therapy Department, and she's our PT. Sherry Muir from the Occupational Therapy Department, and she's our OT. Katie Elliott from Nutrition and Dietetics, and she's the dietitian. And right now we're missing our nurse, Karen Moore, but hopefully she'll be here soon. And finally, last but not least, certainly, is Fred Rodnick, who is the physician for the team, and he is from the Department of Community and Family Medicine. So we'll get started.
Well, thank you all for coming today. So we'll start talking a bit about our patient here, Patrick. He came up to the floor last night from the ER. He was found by EMS, brought in by EMS last night. Bottom line, looks like he had an opioid overdose of some sort. When he came in, he had all the typical signs of opioid overdose. Constricted pupils, shallow breathing, bradycardic, low BP, somewhat disoriented, drowsy. We took a look at him. He was a little banged up too. Some scrapes, bruises, contusions around the head and neck. We did a CT non-contrast of the head at the time, which shows a parietal subdural hematoma. Not that big, about 2 centimeters by about 1.5 centimeters, left parietal region. Overnight, we transferred him up here because a preliminary drug screen showed opioids, most likely heroin, maybe some other prescription stuff in there. His Glasgow Coma Scale when he came up here was about 8 last night. He's up to about 10 right now, a little higher, maybe 10, 12. He's able to stay awake a little more, able to answer brief questions. The management we have from my perspective is we have a load of labs we got to take a look at today to see how he is metabolically. And I know that we have our folks from the clinical lab here rounding with us today, and I want to make sure I'm not missing anything with what I've looked at, because at this point we basically have him on some normal saline IV to kind of clear out some of the metabolites of the rhabdomyolysis that he has going on. Basically, bottom line, I think I'll be able to transfer him out of the unit today. Probably go to one of the floors, keep the fluids going. Need to flush out his system. I think in terms of the subdural, we'll just monitor it. He is improving. His Glasgow Coma Scale numbers are coming up like they should. It may take him a while for him to be fully oriented, fully relaxed. We're going to treat his the detox from the opioids with some clonidine at this point to prevent rebound hypertension. And that's what I'm looking at this point. He does have a number of deficits at this point in terms of his mobility, his reasoning. We've got to take a look to make sure he doesn't have any, it doesn't look like he goes south on anything in terms of renal function and such. So what we can do at this point is take a look at what his needs are as he gets transferred to the floor, I believe. And I'd like some input so we can put some ideas together. Unfortunately, right now, he is not in a great place to be making decisions with us, but I think he'll be clearing up significantly over the next 24 hours or so.
Well, initially, there was many clinical signs and symptoms that would suggest an opioid overdose that might have initiated a condition we call rhabdomyolysis, degradation of muscle cells. And so initially the clinical observations made this suggestion, and so many labs were ordered. Number one, to confirm if that clinical suspicion was correct, and also to determine the degree to which this condition is affecting him metabolically. So there's a whole series of labs that were ordered and completed, And there's a first set of labs that were basically trying to determine whether or not the muscle cells in rhabdomyolysis were in fact being destroyed by this heroin overdose. And there's a lot of labs to suggest that's the case. CK is elevated along with LDH and AST and ALT. Some of the enzymes that are found inside the muscle cells, when they burst, they literally release those enzymes, and they were elevated in circulation, as well as potassium, that's an electrolyte found in high concentrations intracellularly, is also released. Those are elevated. Flip the page. We also have uric acid elevated for the same reasons. So these labs would confirm your clinical suspicions of rhabdomyolysis, which I think was largely probably suggested by his urine color. The nursing staff initially noticed his urine color was, they described it like Coca-Cola. It's kind of a brownish color, common feature in rhabdomyolysis. So to look also along those lines, whenever the myocytes release a bunch of myoglobin, there's a transport protein in the blood that must bind that myoglobin. It's called haptoglobin. When that's the case, haptoglobin levels go way down as they bind up this surplus of myoglobin. So we ran that to make sure that, to also confirm this clinical suspicion. And the haptoglobin really bottomed out at about 8 milligrams per deciliter, also confirming this idea. With all this myoglobin in the blood and being transferred to the bloodstream and filtered by the kidneys, it is a shock on the kidneys to manage this bolus of myoglobin all at once. So we looked at, according to your orders, and we ran a BU and creatinine, two commonly performed laboratory tests to evaluate kidney function. They were both moderately elevated, suggesting that maybe kidneys before were in good shape, but they've been stressed by this myoglobin burden, and so that was also confirmation. And then lastly, we're confirming this with a low calcium level, which is a sort of a rebound problem we see in rhabdomyolysis. We did your drug screen, and your suspicions were correct. Looks like it's positive for morphine, a metabolite of heroin. We did drug concentration levels. You can see they're quite high. The free morphine levels not quite as high as in some cases, so his life is probably not in jeopardy, but this is a serious overdose. As you guys also noticed clinically from the heroin overdose, that his breathing was very shallow and labored, putting him in a respiratory acidosis situation. So according to your orders, we also did arterial blood gas, and it's consistent with a respiratory acidosis of a moderate severity. Since the urine was so discolored, we performed a complete urinalysis to follow up on those urine findings, and had a high specific gravity because all the myoglobin in the urine sample, blood was positive as one would expect. And bilirubin ketones were negative, a lot of protein from the myoglobin. So in short, the urinalysis was also consistent with rhabdomyolysis. So good job clinically. The laboratory results perfectly confirm what you were suspecting clinically.
Do you want to say anything, or do you want to go?
All right, so we're going to move on from some of the concerns from a pharmacy perspective. So again, our clinical suspicion is a heroin overdose, and heroin is within the opioid class, so a more potent version of something like morphine, which you traditionally see used in the healthcare system. Mind you, heroin is much more potent and much more addictive. That's why it's an illicit drug and not used for medical purposes here in the U.S. When he came in, because he did show signs and symptoms of a potential overdose of a narcotic, in the ER they did give him the antidote to try to reverse some of the effects of the heroin, and that antidote is called naltrexone, which he responded to, and we got him his respirations back into a more safe range. One thing we need to continue to be watching over the next 24 hours is to make sure that his heroin, the symptoms of the heroin overdose don't return, mainly because a lot of our street drugs are not pure substances. They are laced with all sorts of other chemicals. He could have kind of a second phase where he will continue to have respiratory depression. Because of the rhabdomyolysis, our big concern is fluid status. So right now he is on normal saline. We're running it relatively quickly. And really we want to continue to watch his electrolytes. The main concern being that his potassium will continue to rise. And if the potassium gets too high, he could be at risk for arrhythmias, which we want to avoid if at all possible. The other thing, since he is slightly acidotic, we will also need to continue to watch his acid-base status and see if we need to supplement with some more base, so bicarbonate being the base that we substitute to help reduce the acidosis. And then lastly, with his overdose, we'll continue to watch for signs of withdrawal and treat them as needed. So most likely we'll use some clonidine if his blood pressure starts to rise too much. We might need to add a medication to kind of help with the anxiety that can happen during withdrawal, but again, that will sort of depend on how things go over the next 24 hours. And we're hoping that since he's a relatively young man, and this is his first time he's ever had problems with addiction, that he won't need long-term detoxification therapies at this point. So hopefully we'll be able to get him into rehab and avoid long-term need for a detox medication.
So when he first came to the floor, we noticed that his Glasgow Coma scale was about an 8. He has improved during his time on the unit. He is getting a little bit better, but he does continue to have some problems with remembering how to sequence events, remembering to use the call light, remembering to follow directions, call for help, that sort of thing. So he is going to need some more support. He's certainly not ready to be out on his own and back home and independent at this point. He's still having difficulty feeding himself with his right hand. We have noticed some weakness on that right side. Don't really know what that was related to relative to everything that happened with him, if that's the head trauma or if that's from laying on that side or kind of what we're looking at, but the right hand is still having some difficulty. He's still really not very alert. He's kind of coming in and out of his alert status, so we would want to keep an eye on that. I don't know if that has anything to do, again, with his medications, if we do need to kind of keep following up with that. But other than that, he does seem to be getting better. He is having some nausea and vomiting that we've noticed, which we think is probably related to withdrawal from the medications, an acute withdrawal symptom. His respiratory assessment, he's breathing a lot better. Initially, when he first came up, he was only respirating maybe 12 to 14 times. He is up to about 20 per minute, so that's pretty good. His neuro exam, like I said, is getting better, but he's still not at a normative status.
So because he was having difficulty in walking with the nurses to the bathroom, they asked for an order for occupational therapy and physical therapy, and because he was having difficulty. So I did my physical therapy assessment of this young gentleman, and what happened as I was walking into the room, he was having difficulty in working the controllers on the TV, which caused several forward answers out of his mouth. So when I was working with him also, I asked him to sit down, and he became very agitated and angry during the session. As I go through my assessment, whenever someone has rhabdomyolysis, you're worried about muscle strength. And he had generalized muscle soreness or muscle achiness. He also had muscle weakness. And so that is an indication of either part of the disease process or maybe long-term drug use. Even though this is our first time seeing it, we don't know how long he's been on this illicit drug use. The other thing that I noticed is that what we do is we typically will have balance exercises. And so typically a 22-year-old should be able to stand on one leg. They should be able to bend down and pick something up off the floor without falling. When I had asked him to do those tasks, he was unable to stand on one leg for 1 second without any kind of support. When he got up out of a chair, we'll typically ask a 22-year-old to stand up out of a chair without using their arms, which should be very easy. He needed his arm support or his upper extremity support, and since he has difficulty using his right arm, it even became an increasingly difficult task for him. The other thing that we asked him to do is we would ask him to reach for things as he's like reaching on the counter or reaching up to his cabinets as he would indicate at home. Again, he lost his balance as he was doing those activities. So he demonstrates some balance activities as well as some weakness problems that we will need to address now and also in the future until he starts to show significant improvement in those areas. He also demonstrated some safety concerns, which was first identified with the difficulty in changing the channel of a TV. As most 22-year-olds can handle changing a TV, and he was having difficulty in doing that. As we were walking, looking for his belongings, he became disoriented on what items he had with him or what he had been admitted, and had no recollection to what he was doing the night before. So that's a concern. Also with rhabdomyolysis, because it's a breakdown of the muscle, it also will cause some muscle swelling. So the muscles are trying to heal themselves, just like if you sprained your ankle, you would have swelling in that area. He is showing some signs of swelling, and as Karen had mentioned, on the right side, he had laid on that side for we don't know how long. And because of that, we have to keep assessing his pulses so that he doesn't have any problems where the pulses will be affected. And we also need to continue to assess his nerve and see if there's any nerve damage from laying on that side for a long period of time. So that's typically what we can see sometimes with just the nerve in the elbow. So those were some of the things that we started to assess. And when I asked him about his long-term drug use, he was very evasive in his answers and didn't want to acknowledge that this was a problem. And when I asked him if his friends had ever acknowledged this problem, he says, oh, you know, it's just like being 22. So I think that that's something that we'll need to think about as we continue to have these discussions.
Something that I would ask that everyone who's having direct contact with a nursing, PT, OT, et cetera, is to keep an eye out for any new bruising. We know with rhabdo, it can also come from trauma. And at this point, we've only imaged his brain, which we don't think that subdural going to be a problem, but depending on how he fell, he may not have had full opportunity to bruise yet, especially if he has a deep hematoma and maybe a muscle tissue or something. So as you work with him, especially if you're noticing some deficits, let us know if we've got something going on with new bruising that we might not have seen yet. We might have to do some more imaging, ultrasound, something like that to see if there's additional cause. And we'll be doing follow-up labs too to check creatinine status to see if there's any sign of additional muscle breakdown.
So for occupational therapy, this is going to be an interesting case for us because we're kind of twofold with him. We went in and did an ADL evaluation, basic self-care, bathing, dressing, brushing your teeth, those kinds of things. He's struggling with all of those for a lot of the reasons that Kim has said. His balance is bad. He's even having trouble sitting in the chair and reaching down towards his feet. So he kind of loses his balance then. So self-care is not good at this point. The weakness and pain in his left arm, or in his right arm, are making that really hard. He's right-handed, so he's having trouble feeding himself. And I also noticed, I think you guys probably did, he's really thin, right? So Katie, that'll be something for you. But I think that self-care-wise, he's not independent. He needs help with that. He's not feeding himself. That's going to be a concern for us. But also what I noticed is that I think he's having some word-finding difficulties. I mean, his speech just doesn't sound like it should, and it doesn't seem like it's because he's tired. I mean, I think we may have a speech deficit as well, and that's probably from where that, that bruising is. So I think we need to keep an eye on that. That might also be an indicator of some other cognitive problems. We're just going to have to really keep an eye on that. Additionally, I try to kind of talk to him about some of his coping mechanisms and, how often is this drug use? And it seems like he's working as a bartender. So I think he has fairly regular alcohol use. He alluded to that while he's working, it's a good time to sneak a little drink or whatever. So I think that might be a part of it. I think that there might be some history of previous treatment for alcohol and drug use. Did you? Okay, I'll let you do that because I kind of got that from him. But I'm very concerned that his coping mechanism is alcohol and drugs and the environment that all goes with that. And so I think if he really hopes to go to law school, we're going to have to talk to him a lot about how he deals with stress and his coping, and I'm sure you're going to do a little bit of that too. So there's quite a bit for us. It'll be a challenge to figure out which things are most important. Do you want to talk? Right, sure.
Well, like Sherry mentioned, he does appear very thin, and his body mass index was 18, which is it's still in the normal range, but that's at the bottom end of the range. So, and what we see sometimes with the alcohol and the drug abuse is a preference for sweet foods. So I did go in and chat with him. He wasn't too interested in talking about his diet with me. He didn't want to talk to the food police. But I did get a couple of things out of him. And it seems like what he is eating at home is just kind of grabbing whatever he can get that tastes good. So he actually eats a lot of those like Little Debbie snack cakes, the sweet things that are just quick and easy. So kind of coming into this, probably have a risk of some nutrient deficiencies. But I'm also really concerned about this right hand. I mean, whenever when eating becomes a challenge because you have a physical limitation, then it can be frustrating, and then we start to get on this slippery slope. I'm not really sure with the alcohol intake, and I would probably look to maybe nursing or to really get a better idea of what the alcohol intake is like. You might start to see some issues with like some B vitamin deficiencies that we might be concerned about, at least a multivitamin, and then assessing that. So, Sherry, I think you could talk some more about that right-handed issue. Correct.
He had a blood alcohol of 0.03, so he's had some drinks, not legally drunk, but he had some on board.
Well, I haven't had an opportunity yet to talk with Patrick himself because all of you have been in there assessing him. But I did have an opportunity to talk to his parents who arrived early this morning. And of course, they are very distraught. I learned a little bit about his background from his parents. He comes from a fairly affluent family. He lives in Chicago. He has health insurance. That's always something that we need to find out. And he has very good coverage, so that's not an issue. His parents talked about his previous drug use, and it actually started in middle school, where he experimented quite a bit with marijuana. And then when he got to high school, he used cocaine and alcohol, both. He was in a drug rehab program when he was a senior in high school, an outpatient program, and that seemed to help him, at least for a while. He is now a senior here at St. Lucie, and he has been accepted into law school and is looking forward to that for next year. He's very bright and has a very good academic record, which is in his favor. He also has had no legal problems. He's never been arrested for possession or anything like that, so that's good. He does work 15 hours as a bartender. He lives in a second-floor apartment with 3 roommates, and they live off campus. His father is a businessman, and his father also told me that he was a recovering alcoholic himself. His mother, interestingly enough, is a clinical psychologist, and he has an older sibling and a younger sibling that's still at home.
Do you know how long the dad's been sober?
Oh, I think quite a while. I think he said a long time.
Okay.
He's been sober, and he went through rehab himself in order to accomplish that. His parents talked about the fact that he was super anxious most of the time, and they've always believed that his drug use was self-medicating, trying to help calm his anxiety because he always wants to excel at everything he does and just gets so anxious, and the drugs help take the edge off of his anxiety. But they're very, very concerned about him. They're going to be very supportive, I think, as he goes through the treatment and rehab. They'll do anything that they need to do to help him. So, and he does have the resources, which is a good thing. Any questions about his social history?
I guess I just have a couple general questions. With this application to law school and this acceptance, will this impact that? Will that be reported to them in any way?
No, I don't think so.
Okay.
His confidentiality would be maintained, and again, if there were no legal
So
issues.
the police weren't called or whatever
No.
when they found
No.
him? Okay.
No.
And then I guess I just have a general question about his anxiety. Do you know if he's ever been on any anti-anxiety medication or anything? When he went in treatment before, did they talk about that? If he's self-medicating with drugs and alcohol, I mean, we need to probably work on that when we can. I don't know if we can do that now to start that before he leaves here, or do we have to wait until this is out of his system?
His parents didn't indicate that he'd ever taken any medication for the anxiety. They just acknowledged that he was very anxious. They didn't mention depression, so I don't think that's an issue. I think it's just been primarily anxiety.
Yeah, this probably wouldn't be the best time to start an agent with everything else going on in the system right now, especially with opioid withdrawal. Everything's in a hyperactive drive. Nausea, vomiting, stomach upset, etc. And even if he were willing to start a medication at this point, most of the meds that are gold standards for anxiety-related issues like SSRIs, etc., often have side effects that mimic some of these he's already going through, so we don't make necessarily a bad situation worse. I did have a question, though, Tim, with one of the things I worry about with some of the folks we see that are using heroin or the impurities, as Erica mentioned. And would things like fentanyl or MDMA, ecstasy, et cetera, would those things have been picked up in our drug screen?
Not in the screen.
Okay.
But we have individual ELISA assays for some of those.
Okay.
And what we don't have, we have a mass spec.
Okay.
So we can analyze for any of them.
Okay.
But I'd have to look at it on a drug-by-drug basis.
Okay.
But most of the screens would not be.
Okay, the reason I ask is that sometimes with a complicated detox, and we don't know yet at this point what we're looking at, but with some of these complicated detoxes, we can get into more of the fat-soluble street stuff in there that can really cause deficits for quite a while. PCP, marijuana, a few other ones that are fat-soluble can have residual symptoms for a long time. So depending on the next day or two goes, I'll let the team know who's picking them up on the floor, that if things don't progress quickly in terms of him coming back with cognitive abilities, balance, et cetera, that we've been talking about, that might be something, Eric, if you're working with the floor team to look at, and we can see what some of the common things that have been going through the area lately are, and maybe do some more specific screening with samples.
Yeah, PCP would have been on the screen.
That would have been great. Okay, good. So that's one thing we don't need to worry about. Okay.
So I guess another question that I have is he going to be out of here by Monday? It's Friday, right? Thursday. Got him yesterday, Thursday. Because if not, then I think we're going to have to think about school and how willing he's going to be to stay, right? And how willing his parents are going to, he's 22, he gets to leave when he wants. But are they supportive of keeping him here? Will they support us in that? Or are we going to think he's ready to go by Monday? And then if not, I think we need to be ready how we're going to address that with him for school. So we're a united front. If he wants to leave so that his professors don't know he's out. What are your thoughts on that?
Well, I definitely think we're going to need to keep him for another couple of days until his renal function improves, until we have a better idea from a cognitive standpoint if it's just a short-term deficit or is this something that's more long-term. So he's definitely probably going to have to stay through the weekend. And additionally, we're probably going to have to get psych involved and sort of get him into the rehabilitation process, whether it be an outpatient type program or a short inpatient stay followed by kind of a counseling thereafter. So I certainly think he's going to be here through the weekend until we can sort of see a little bit more as to the full extent of this overdose and the extent of his deficits, and get him a plan going forward so that he can deal with his addiction.
Yeah, because already this isn't a simple detox. I mean, he's got residual
Right.
weakness, he's got cognitive impairment, and most people, you know, coming off of heroin, they're going to feel lousy, they'll have all the GI side effects, but he's already showing some residual problems. And that's really where I know that the floor team's going to count on all of you who are working with him regularly to give them the feedback we need about appropriateness of discharge planning. Because what we're going to be looking at is only one snapshot. You guys will be working with him much longer than what the floor team in terms of the physician team is not going to be spending as much time. So the feedback you give is going to be crucial in the planning.
One thing that is in his favor, I think, depending on his relationship with his mother, but his dad needs to go back to Chicago because of his business, but mom is planning to stay here as long as needed. She already has a hotel room nearby, and she's planning to stay as long as he needs her. So that could be good or bad.
I was going to say, did you get a sense of whether that's good or bad?
Well, not from him. This is just her plan, so I don't know what his plan will be. But she wants to be here to be supportive and helpful.
And what does his, how does he have to be cognitively to be able to make the decisions of his own discharge? Where does he need to be for that? Or who makes that decision when he is cognitively aware enough?
Unless something untoward happens, he should have the capacity to understand his situation, his options, and we'll know that through conversing. Often the first people who know that someone has the capacity when we have mental status changes is the nursing staff, because the best way to understand capacity for this is through conversation and consequences of actions, decisions, etc.
His parents are also very supportive of rehab, whatever is recommended for him, and I think they have the means to pay for that. It's good that he has insurance, because I understand that in St. Louis, the publicly funded rehab programs have months, the waiting list is months long because of the epidemic of heroin overdoses and addictions that we're seeing in this area. So thankfully, I think because he has insurance, he won't have that long wait that he would otherwise.
So if he does inpatient, how's that going to affect school?
Well, that's something he has to work out with his advisor and the faculty that he's working with. They could probably work out something so he can continue. I don't know. That's yet to be determined.
I would think, I agree with Sherry, I think that's something that we need to work out ahead of time, because if I was 22 years old and thought that if my delay in school would delay my graduation so then I couldn't be admitted to law school, I may be hesitant to go to rehab. So I think that's something that we have to assess and be ready for when he asks that question.
And he might be able to do both. He might be able to take his classes and and be in a rehab program, whether it's residential or outpatient. I'm sure they would want him to be able to continue in school just as much as he wants to.
Because ultimately, if he has the capacity to make the decision, then he's going to be making the decision.
Right, right.
I mean, have you all gotten a sense, does he feel like this is a problem? Or this was just a one-time event and he's not so worried? What do you think?
No, I think he has a long history of...
Well, I know we know he has a long history. I'm just saying, what is
does
he
he?
saying? Yeah, does he, I didn't get that sense yet, did you, Kim?
I did not get the sense that he thought that there was an urgency to go to rehab.
Yeah, see, I'm really worried that he's just, by Monday, he's going to decide, I'm fine, I can go. And we won't stop.
But
until
metabolically, he may not be near
Right.
ready yet.
That may be in our favor. That may be in our favor, I think, to give us just a few more days. Okay.
So it sounds like we all know our next steps. We'll get our charting done, put our
Yeah.
steps in there for transferring to medical floor team. Once we get that together, I won't be involved anymore, but I know that you'll be picking up with the medical floor team that will be managing his care. Anybody have any further points to make? How about questions from the audience?
This is maybe at the social work, but I guess I can answer it. Because it was a heroin overdose, is there ever a time where you have to report it, or can you report it because of confidentiality?
No, I don't think that would be a reportable report to do, like the police.
Like anything like illegal, will there ever be like an instance where you have to?
No, I don't think so. It's health providers, I don't think so. If he was caught with it in his possession or had it in his car, and they searched the car and they found it, that would be another issue, but I don't think we're obligated to report it.
The only question that I would have with that is if this person were another health professional. I've had to report physicians that I've treated for symptomatic withdrawal at the jail in Clayton, okay? And I've had to report that as professional duty. Otherwise, though, in this situation, no.
Do you report to the police or to his?
Board of the Healing Arts, Missouri
Okay.
Board of the Healing Arts, which is the licensing agency for all of us.
So attorneys don't have the same requirement?
You guys are saying you had like a good amount of insurance coverage. So, like for instance, in this case where it was a drug overdose and self-inflicted, would the insurance company just turn that down right there?
Repeat the question so they hear it.
Okay, the question is, would the insurance companies turn down paying for this care because it's a self-inflicted type of thing and it's drug overdose, drug-related? It shouldn't. I don't think legally they can do that. It depends on the policy in terms of how much coverage he has for anything, but his parents indicated that it was a broad coverage and they were not concerned about the coverage for him.
Most insurance policies have a specific coverage for drug and alcohol rehab or for certain types of things. So it's 30 days or 60 days within a calendar year. So as long as he hasn't used that, they are obligated, to provide that. If he's used it before, that's a whole different story.
Right,
Then
because
they
I've
can-
certain scenarios where people are trying to get treatment
Right.
for cancer and stuff and just get rejected and fly out.
Yeah. Yep.
Saying that he can't really use his right hand properly right now, is it possible to say that he was bounced back and go back to school on Monday? Is it, can his hand really get better?
Pardon? Oh, yeah, it's a good question. He probably will not have full function by Monday.
Repeat the question.
Oh, I'm sorry. The question was, if you guys didn't hear it, since his hand is so impaired, his right dominant hand, could he just go back on Monday and be fine to go to school? The answer is probably not. So we could do a couple of things. If he insisted on going, there's some adaptive equipment that can help you write. There's all kinds of different things that to help hold the pen or to do whatever. Or if he has a computer like most of you do, we could look at a modification for that. There's some voice to text things. You guys, your iPods are great to record class, right? So we could do some things like that as an interim while we worked to get him better. And then we would also, there's a simple thing called a U-cuff, and you can put, it's a little pocket that goes on your palm, and you can put a pen in it to write. You can put your toothbrush in it. You can put a fork or spoon in it to eat. That's a $5 adaptation that makes you quickly independent. So there are things we could do for him if he insisted on leaving. But to be honest, I wouldn't offer those too fast if we want him to stay, right? I'd be like, oh, we really need to work on that arm. Or,
I think there's a bigger question, though, related to your question, that is, what is the cause of his right arm weakness?
Yeah.
If it's related to a falling on the arm, and it's a tendonitis or something like that, that's a different story. If it's due to head trauma, for instance, identifying the cause of the right-sided weakness is more important than how quickly we get back to school.
And or the rhabdo. Because if there's destruction of the muscle tissue, so you could have a brain problem causing it from the bruising, the bleeding there. You could have the rhabdo that could be muscle destruction, or, you know, it's a coordination and cognitive kind of thing. You can't put it all together to pick it up and to scoop it or whatever. So, I mean, we'd spend quite a bit of time, probably PT and OT together, trying to figure out why he's having these problems.
And it could be a peripheral nerve, which means the nerves that go down the arm. By laying on it for a long period of time, he could have caused that numbness and tingling and muscle weakness. So Tim is right. We have to find the source and then determine the treatment and how long it would take.
What else? Go.
If you think, or do you think that his loss of balance and muscular trouble is due to long-term drug use? And if so, are you going to prescribe physical therapy immediately for him?
The question was, do I think that the muscle weakness as well as the balance or imbalance of the patient, do I think that they're attributed to the long-term drug use, and would I treat them as a physical therapist? Did I get the question correct? The answer is yes, because, again, I'm not definitely sure what it is. It could be the long-term drug use, because long-term drug use does result in long-term muscle weakness. And so muscle strengthening has been shown as a benefit of starting that and then having him see the benefits of muscle strengthening. We know that exercise can release endorphins or and catecholamines to give them to reduce the anxiety, to give them more of an empowerment and a euphoria. So yes, aerobic exercise is very beneficial. You all know when you exercise that you feel much better after you exercise than when you're in the library studying for hours on end. And then in regards to the rhabdo, it's like a rhabdomyolysis. It's a time will tell type of thing. So I have to make sure that I still work on the muscle strengthening right away so that he doesn't continuously cause muscle weakness or progressive muscle weakness or loss of muscle.
The other advantage of having PT work immediately with our patient is he's at risk for another fall or other problems immediately. So not only is the long-term rehab and strengthening important, but the immediate working with folks. A lot of times there's falls in hospitals. People get out of bed, can't manage a walk to the bathroom, and they can injure themselves again. So there's a lot of immediate intervention too that can do in terms of strengthening.
And a lot of it is repetition with safety awareness. The repetition. So Sherry and I work as a front, and we both give the same cues, we both give the same information so that the patient continues to hear it throughout the day so that we can keep building those concepts so the patient can have some memory for them.
Who else?
If the drugs that you were taking, he was taking were laced with any other kind of drug, are the prescriptions that you're giving him to reverse the effects of the heroin, can those react with any of the drugs that you're not really sure are active?
Yeah, so sometimes it can get a little bit, oh yes, sorry. So the question was the anecdote that we gave to try to reverse the heroin, if it were, say, laced with something else, would it potentially cause an interaction? Is that sort of the gist of the question? Potentially, there is a very good chance that it was laced with something else. Most of the substances that are on the street are not pure. The anecdote that we use in particular just focuses on the receptors in which that drug works, or opioids work in general. So it's not necessarily going to affect some of the other drugs that potentially might be in the illegal substance, but it might start presenting some of the other signs that were originally hidden. So it's sort of the heroin overdose was what we initially thought. And if it were laced with something, once we corrected for that overdose, that's when the signs of that particular agent would start showing up. And that's sort of why the initial 24 to 48 hours is sort of the most crucial when you're dealing with an overdose, because that's when sort of all those unknown substances start to sort of come up as a potential issue. So that's something we will definitely be watching for. The biggest concerns, at least in the St. Louis area, and when it comes to stuff that they're lacing it with, is fentanyl, which is even more rapid-acting type of drug that's similar to heroin in how it works. There's also concern that it could potentially have some methamphetamines mixed in there. And so that can kind of cloud the picture as to how we're going to treat them going forward. So it's something we're definitely going to be watching very closely over the next 24 hours to see if there's anything else that might be in the system that we just didn't know about initially.
Go ahead.
I know with like an overdose of that type, you would give them additional treatment with that stuff, and but afterward, would you gradually ease them out of withdrawal with like methadone or something like that?
So we're hoping to avoid needing methadone. At this point, we're going to treat his withdrawal type symptoms. So the most common going to be GI related, as well as tachycardia and hypertension. So his blood pressure is going to rise, his heart rate's going to rise. We're going to try to treat those specific symptoms. If he continues to have problems, then, and now that we're starting to get a little bit more information about his length of drug abuse, it might be something we have to think about in the long term. Is he going to need methadone to sort of wean himself off? But our initial goal is to try to avoid that if we can.
An important point about methadone is that you don't use methadone to treat. What you use methadone is to avoid people buying drugs off the street and shooting up with dirty needles. That's why you use methadone, is so you can have a pure medication that is monitored and lasts for more than 24 hours. So ideally, you would only use methadone if this guy is going to go out and start using again. So that's why this whole idea of getting an idea on his involvement and dependence on the opioids is really important for forward. Because quite honestly, we would not treat anything other than the symptoms of the withdrawal, the nausea, the vomiting, maybe some of the agitation. That's what we would normally do. He would leave the hospital not on any opioids. The question would be, if we would have to start methadone, it would be because we're trying to work with him to avoid using heroin.
Go ahead.
Yes. Since he has like a history of not only recreation using drugs but like abuse, like would you be hesitant to put him on any sort of like anxiety or depression kind of medication because in fear that he may abuse that?
Yeah, it's definitely going to change the potential drugs that we have to choose from. So when it comes to treating anxiety, one of the agents that we tend to use for kind of quick relief of anxiety symptoms are in a class called benzodiazepines. So your Xanax and things like that. I've maybe heard of those. But they themselves have abuse potential. So we're going to avoid trying to use those types of medications in someone who has a history of drug abuse. And so we would go with agents that don't necessarily have that abuse potential. The downside with those is it does tend to take longer for them to really start working. So that's really where the behavioral side of things comes into play. I forgot to repeat the question. So on the back end, the question was about would we be worried about the drugs we'd use to treat his anxiety given his history of substance abuse.
Okay, I think we'll come on today, and thank you for your attention.
That was either Irma or the Holy Spirit.
Either way, it's time to go.